In both psychiatry and neurology, there is a cluster of symptoms that crosses diagnostic boundaries with devastating consistency. Whether a patient is diagnosed with major depression, schizophrenia, or Parkinson's disease, they frequently suffer from profound fatigue, inertia, and psychomotor retardation, a severe drag on their physical and mental initiation of movement. For decades, the standard frontline response for these mood and motivational deficits has been to prescribe serotonin-targeted agents, commonly known as SSRIs. This creates a clinical paradox. While these serotonin uptake inhibitors often successfully alleviate generalized mood and anxiety symptoms, they frequently leave the specific heavy inertia of avolition completely unresolved. Clinical data shows that in certain patient populations, serotonin enhancement actually exacerbates these feelings of lassitude and lethargy. This widespread therapeutic failure stems from a foundational error in how we conceptualize motivation, specifically regarding the mesolimbic dopamine pathway. For years, an entrenched heuristic has dominated both public understanding and medical training, the belief that dopamine serves as the brain's pleasure chemical, and that a lack of motivation is simply an inability to feel joy. Treating profound inertia requires discarding this myth entirely to look at the actual neurochemical driver of action. The textbook model draws a direct line from stimulus to dopamine release to subjective reward, but depletion studies prove stripping dopamine doesn't strip hedonic joy. Actually, mesolimbic dopamine governs behavioral activation, generating the physical figure required to overcome obstacles. We can view this through the behavioral economic concept of willingness to pay. Physical and cognitive exertion are biological response costs, and an organism has to calculate if the labor is worth the wage. There is a sharp clinical distinction between a patient's capacity to enjoy a rewarding stimulus and their neurobiological drive to obtain it in the first place. This neurochemical separation forces us to redefine anhedonia. It is rarely a monolithic deficit of joy. Instead, in many patients, it manifests as a highly specific deficit in effort allocation. Mesolimbic dopamine does not dictate what an organism likes. It dictates exactly how much labor it will endure to acquire it. To understand this mechanism, researchers had to translate subjective psychiatric complaints like fatigue into quantifiable objective behavioral data. This led to the development of the concurrent choice task, a laboratory standard designed to isolate cost-benefit analysis in rodents. On one side, a lever requires significant labor to yield a preferred carbohydrate pellet. On the other side, less preferred lab sow requires zero effort. Under baseline conditions, healthy subjects reliably invest extreme physical labor, ignoring the free chow to repeatedly press the lever. This behavior plots perfectly onto an economic demand curve, mapping response output against the rising price, or ratio requirement of the lever presses. Dopamine levels represent the organism's purchasing power. It is the available behavioral energy they can invest into paying that physical price. When neurochemical conditions are fully optimized, the intrinsic value of a high-tier reward easily overrides steep physical obstacles. To test the system, researchers introduce a targeted perturbation. By administering tetrabenazine, or TBZ, they inhibit vesicular transport, rapidly depleting dopamine transmission in the striatal complex. The behavioral shift is immediate. The subject entirely abandons the high-effort lever, instead settling for the free, low-value chow. Looking at the data, the y-axis collapses. Consumption plummets against the rising price, specifically along the dopamine-depleted trajectory. Crucially, this is not an appetite suppressant. The dopamine-depleted subject suffers no loss of overall caloric intake. They are simply eating the free food instead. Furthermore, their hedonic taste reactivity remains perfectly intact. If you remove the lever and hand them the preferred carbohydrate pellet, they consume it enthusiastically. In economic terms, the subject is experiencing an increased elasticity of demand. They are highly sensitive to price changes measured in physical effort. The organism's behavioral purchasing power has contracted. Dopamine depletion engineers pure effort shyness. The hedonic capacity is untouched, but the drive to overcome obstacles is annihilated. This brings us to therapeutic validation. Researchers tested known psychopharmacological agents against this TBZ-induced effort shyness to see what could reverse it. They started with the clinical front line, standard serotonin uptake inhibitors like fluoxetine. The serotonin enhancement failed entirely to restore behavioral activation. In some instances, higher doses of these SSRIs actually deepened the impairment. They then pivoted to catecholamine transport inhibitors, drugs like methylphenidate and modafinil, which directly augment dopamine transmission. This chart provides empirical proof of behavioral rescue. In the top row, catecholamine intervention yields a dose-dependent restoration of lever pressing. Subjects return to the high-effort task. In the bottom row, an inverse correlation appears. As motivation is restored, consumption of low-effort chow drops accordingly. Specific catecholamine-driven agents are a biological necessity for restoring the currency of physical effort. These preclinical rodent models translate directly to the human clinical realities of major depression, schizophrenia, and Parkinson's disease. The human translational equivalent of the choice matrix is the effort expenditure for rewards task, or EERFT. The EERFT requires human subjects to calculate trade-offs. They choose between a low-effort, low-reward option, like a few easy button presses with their dominant hand, and a high-effort, high-reward challenge, requiring rapid tapping with their non-dominant hand. Healthy volunteers naturally scale their effort to the probability and magnitude of the reward. But patients diagnosed with these specific psychiatric and neurological disorders show a severely blunted response. These human patients exhibit the exact same effort shyness seen in dopamine-depleted rodents. They actively avoid the high-effort options, even when the monetary reward probability is heavily stacked in their favor. And mirroring the animal data, this is not a loss of pleasure. These patients generally maintain intact in-the-moment hedonic liking of the monetary rewards when they receive them. Human psychomotor retardation and avolition are rarely secondary emotional reactions to sadness. They are primary, mechanical deficits within the brain's cost-benefit calculation matrix. Executing these complex cost-benefit calculations inside the human brain relies on a highly specific and interconnected underlying neural architecture. This distributed network includes the ventral tegmental area, nucleus accumbens, ventral pallidum, and anterior cingulate gyrus. Disparate psychiatric manifestations, the anergia and depression, avolition in schizophrenia, and psychomotor retardation in Parkinson's all trace back to failures within this shared circuitry. This aligns with the NIMH research domain criterion approach, which prioritizes targeting these specific neurobiological circuits over relying on broad, traditional diagnostic categories. It instructs the clinical field to abandon the vague diagnostic umbrella of anhedonia when diagnosing a lack of motivation. When patients present with severe effort shyness, precision psychopharmacology requires targeting catecholamines to rebuild that motivation rather than relying blindly on serotonin. Motivation is not the abstract pursuit of pleasure. It is the precise, mechanical, neurochemical calculation of what a goal is actually worth in both sweat and time.